Good afternoon or almost afternoon to everyone. I want to acknowledge I'm coming to you from the traditional unceded territory of the Algonquin Anishinaabe peoples. I use the pronouns she, her, and elle. And as we all know, this is virtual. I've got a blurred Zoom background today. Shoulder length hair, that's pretty frizzy because of the humidity here in Ottawa. White blouse and a purple and white striped sweater with some purple glasses. And I'm grateful to be here today moderating this session, this panel. We've talked about a lot today, a lot of recovery and a lot of great ideas, but I would argue that we can't do that until we recuperate. So this session is all about health. It's about mental health. It's about physical health. It's about our frontline health workers, our care economy, and it's also going to focus on our Indigenous health and well-being, not only from the pandemic, but issues that existed before. I'm going to be honest, some of this is heavy. Much of this is sensitive, and it might even be triggering. If you take a look at that bottom right-hand corner, we're going to pop up some resources here to start. We encourage you to, reach out to health professionals or EAP if you're affected through the course of these discussions and following it. We're going to pop up some resources through it. And what we're also going to do as we loop back afterward with an email is provide a bunch of other resources that many of our panelists have committed to and that we have on hand on our website as well. So I am just grateful again to be moderating, and I'm going to, without further ado, introduce our esteemed panel here today. We're going to give them each the floor. They're all going to present. We're going to come from different angles into the middle. Then we're going to look at the middle and come out together. And I look forward to answering. We've got time, hopefully, folks, for lots and lots of questions as well. So I'd like to introduce our panelists today. We've got Jennifer Bernard, who is the president and CEO of Women's College Hospital Foundation. We also have Bruske, who's the president of the Canadian Labour Congress. We have Lynn Groulx, who is the CEO of the Native Women's Association of Canada. And we have Karla Thorpe, who is the interim vice president, organizational performance and public affairs at the Mental Health Commission of Canada. Thank you to all. And Jennifer, we'll start with you today. Thanks.
I'll make sure I'm not the first person on mute. Well, it's so wonderful to be here. I'd like to thank the Canadian Chamber of Commerce for inviting me. And I'd like to say hello to all my fellow panelists. I'm thrilled to be among you. This topic is near and dear to my heart, of course, being in healthcare. And I could speak for 10 minutes, but I've timed myself and it's about 4. So because it's so important. So what we learned over the pandemic is that I think what we've known for many years is that one size fits all population health solutions overlook important differences, which include sex, gender, social determinants of health, like where you live, access to a family doctor, your economic status, access to transportation, and one size does not fit all. And so what we saw, particularly with women who were on the front line right from the beginning of the pandemic, our nurses, our long-term care workers and caregivers, they were marginalized almost immediately. And they were the most affected by the pandemic. And I think we all agree, without healthy women and reaching the most vulnerable, we can't beat COVID and our economy cannot recover. And so I feel strongly that a strong workforce has to include strong, healthy women. After all, we are 51% of the population. And we make up a huge portion of not just frontline workers in healthcare, but we are the caregivers and we are the teachers and we are in retail and we're in many sectors. And many new immigrants are also women and we're a country of immigrants. So the pandemic showed that the healthcare system isn't reaching everyone. We don't have equity, we lack data, we lack representation, and we don't even understand those who are left out. So for me, I came to healthcare and I came to Women's College Hospital because it was the first hospital women could practice medicine in and become doctors, founded by Canada's first female doctor. And we are still the only women's hospital in all of Ontario, and there's only 3 women's hospitals in all of Canada. And you juxtapose that to 13 children's hospitals, and it tells you how we feel about women. And I would say COVID in particular showed the health gaps, disproportionality across the board. And when we looked at the vaccine uptake, I think a lot of people thought vulnerable populations weren't taking the vaccine because they were afraid to. Well, they didn't have the information. And when we gave them the information, we found they lined up at our hospital, they lined up in the rain. And so when you have a vulnerable population, you really have to go to them and you have to bring people that reflect their community, and you have to make sure you give them the information they feel comfortable. If we want to really focus on mental health, which I think is one of our key areas today, we know that 1 in 5 Canadians suffer from mental health challenges. And at our hospital during the pandemic, last year alone, we saw 22,000 visits. We have the largest mental health care program for women in the country, and we were overwhelmed with calls. You know, home is not safe for everyone. Being at home, gender-based violence went through the roof. We saw sexual assaults through the roof. We saw addiction through the roof. So mental health issues got much worse for women during the pandemic as well. And most people under 40, almost half Canadians, experience mental health issues, disproportionately women. I'll just give you one quick stat. 1 in every 5 people who give birth struggle with depression and anxiety, postpartum depression, making mental health challenges in pregnancy more common than diabetes and high blood pressure. That's just one snapshot. So we know that we have to have representation in healthcare to reach women and to reach the vulnerable, which are often one and the same. And we know that we're not doing a great job. We have lots of work to do. We have lots of evidence now of where the gaps lie, and we have lots of data to collect. And I'm hoping that through panels like this, there'll be a bright line shined on the policies that need to change, the integration nationally that we need to have to tackle these problems. And quite honestly, just actually putting women at the top of the list in terms of the vulnerable.
Thanks, Jennifer. And there's so much we could pick up on there, but you're picking up on a theme that's actually permeated through the day about data as well, right? And that need and your ability to name those stats has been much appreciated. B, I know that you're going to pick up on some of what Jennifer had said here as well, and I'm going to pass the floor to you. Thanks.
Yes, thank you so much for that introduction, Leah. And I'm coming to you from Treaty 1 territory, home of the Anishinaabe, the Oji-Cree, the Dene and Dakota people here in Winnipeg, Manitoba, and homeland of the Métis Nation. I'm absolutely thrilled to be here today on behalf of Canada's unions and honored to be taking part of this panel of such powerhouse women on such an important topic. And I am going to be picking up on what Jennifer started speaking about, which is the issue of a strong workforce in the care economy. It's absolutely no secret that the gendered impacts of the COVID-19 pandemic have hurt women the most, especially those, as has already been pointed out, that those women who faced other forms of discrimination, marginalization, including young women, Black women, Indigenous, racialized women, newcomers, women with disabilities, as well as queer and trans communities. And at the beginning of this pandemic, we know that more than 1.5 million women lost their jobs. And as women's participation in the labor force fell from a really historic high to its lowest level in over 30 years, many of those who were left working were on the very front lines of the crisis. They were the teachers, the nurses, the long-term care and personal support workers, the early childhood educators, and many others in the paid care sector. They are the ones that were keeping our communities safe, healthy, fed, and supported, and they were doing all of that while they themselves faced increasing risks of exposure to the virus, higher exposure to violence and harassment in their workplaces, and inadequate access to personal protective equipment or paid sick days. Overwhelmingly, it was the caring labor of women, both the unpaid and underpaid, that helped our economy and our communities actually weather the impacts of this pandemic. And for those women who left paid work to care for their children or to support their educational needs due to school closures, and for those who re-entered the workforce to help meet the demands of our extremely stretched healthcare system, to keep things moving, it was quite stressful. It's not enough for us as a community to recognize their sacrifices and their commitment. We believe that our federal government has a really important role to play to address the caring crisis by growing the care sector with good jobs that absolutely value women's labor appropriately. We want to make sure that we can ensure that care services are in place to reduce and redistribute women's heavy and disproportionate load of unpaid work. According to the International Labour Organization, women perform 76% of the global unpaid care work, 76%. That's completely unsustainable. And studies show that women are struggling with the pandemic adding to their stress, right? It's impacting their mental health and it's threatening their economic security in many ways. Beyond recognizing the commitment and sacrifices that they've made over the past 2.5 years, we believe that Canada needs a coherent strategy for care and increased investments in care services that support families and our communities. And that has to include, absolutely has to include decent jobs that are full-time jobs in the care economy that offer benefits and fair and decent compensation based on the value of caring work. It also means strengthening public services to ensure that the labor related to caring for others is reduced and redistributed instead of by default falling to women. It's part of the reason why unions in Canada are calling on the federal government to create a care economy commission to study, design, and implement a strategy to address this crisis of care. We know that comprehensive care policies yield positive health, economic, and gender equality outcomes that benefit parents, children, older persons, and those living with disabilities. And we know that women can only equitably participate in the labor force when they know that their loved ones are taken care of, whether that's appropriate childcare, elder care, or care and supports for those family members living with disabilities. So a care strategy, in my mind, is absolutely critical if we want to ensure an equitable and a gender-just economic recovery. And I just want to quickly share a quick story of Tess, a personal support worker in Ontario, whose journey to becoming an advocate for workers in the care economy really illustrates some of these points. She was born and raised in the Philippines, migrated to Canada 20 years ago, and worked incredibly hard while going to school to support herself, to get her education to become a personal support worker. And she quickly rose up the ranks within her workplace to become a leader in her union. As a representative of workers of color and women in her workforce, her advocacy absolutely highlighted care workers' really poor working conditions and that they've only gotten worse since the pandemic began. What she actually said to us is, in her own words, is that when the pandemic struck, the world changed immediately. And despite that change, those workers, those long-term care workers, they stood beside the most vulnerable residents, shielded our patients, worked tirelessly and struggled to find the appropriate protection, had a lack of information from employers, from unions, and from government that was truly frustrating and scary for them. And she felt that, when she left the house in the morning, would she be able to come back and keep her family safe after being on the front lines, being in a care system that is broken and that's forgotten, that's been ignored for decades. So this is the time for change and for investments. It's not just for our generation, but it's for the future generation. Because the reality is, at some point, all of us are going to need caregivers in our lives or the care system. And so it's absolutely vital that we invest properly and that we make sure that those care systems are robust. And that means making sure that the care workers are also being taken care of and that they're properly compensated and that they're not burning out and that they're not falling victim of harassment and violence within their workplace.
Thank you so much. And thanks to you, your colleagues in the Labour Congress, for the focus on the care economy. I've been privileged to be partnered with you any number of times over the years, you and your colleagues in front of parliamentary committees, and for the ability of us, for where we sit with business and labor, to go sit beside each other, agree with each other more than we disagree. When we disagree, it's respectfully. And I think some of those members could take some lessons from us some of those days as well. But really, having your pedal on that and the idea of a commission is wonderful. Thank you. I'm now going to I'm looking at a different side of the screen here. Lynn, it's a delight to have you here today and welcome you to the floor for some introductory comments as well. Thank you.
Well, thank you very much for providing this opportunity to express our experiences during COVID and what that's been for us and what we're doing about that. And first, I'd like to acknowledge the unceded Algonquin territory I am on today in Gatineau, Quebec. So I can say that prior to COVID, we already had a crisis in the community, a very severe crisis that we know has been declared to be a genocide in Canada. We know this now. So I can say that that situation, and on top of that, a COVID, of course, we saw an increase in the violence against Indigenous women. So we were dealing with all of those situations in our frontline services that we do have for Indigenous women. And we had no choice but to adapt to that situation. And it created a situation where we had services that are usually provided by our own elders and community that are never done online, that we had to actually adapt and bring them online. COVID first came, the elders said, no, we can't do these kinds of ceremonies. We can't do these things online, but we had no choice, and they decided to move forward with that. So we did that, and we moved forward with our frontline services online on some of these services. And we were able to service over 12,000 women. And I can say to you beyond any doubt whatsoever that it was an absolutely critical decision that we made. Not only was it helpful for all of those women, we discovered that we can actually help women that are isolated in remote communities that we never would have thought we could do prior to COVID. So that's a bit of a silver lining there, because otherwise we would still be sitting here. We have recently opened a healing lodge where we're able to bring in approximately 60 women per month. Well, that's only 600 and some women per year. And online, we're able to help a lot more women. So that's a very important push that we got, in a way, silver lining, I'm going to call it, to force us to look at things differently, to be able to provide those kinds of services that we never had before. And it also pushed us to develop our own model, right? Because what was important, what we knew already, but we have more. It's clear to us now that these services that we have to be developed by Indigenous women for Indigenous women if they're going to work. I mean, the mainstream services are not working well for Indigenous women. If they were, we wouldn't be reinventing the wheel. So we did that, and it pushed us to go further with our concept. So we do have one resiliency lodge, our own healing center in Chelsea, Quebec, and a second one that we're building in New Brunswick, which is, the concept is that is culturally based, spiritual and emotional assistance, and it is led by our elders and designed by Indigenous women. So we again, that silver lining, I think it's 3 times that I said it now, because I'm taken aback at such a negative situation that happened to us, and yet we found a way to get some good out of that. That's my message today, that we had to adapt. We worked with our community, with our elders, with our youth to find solutions, and we did find some. And we're hoping to continue to do the work that we have to do to be able to have the resources we need, because we're under-resourced, and to continue to work on those 231 calls for justice that were in that national inquiry report. Just because we had a pandemic or we're coming out of it, it doesn't mean that we don't continue to work on these bigger issues that we have. And in our case, it's a genocide of Indigenous women. I would like to keep going, but I have to share this space with everybody. So I will stop there. Thank you so much.
Lynn will come back, and thanks for those comments, the reminder. And as well, that those silver linings, right? It was what it was, it is what it is, and how we've been able to negotiate through that is very much appreciated. Mm-hmm. And as I turn and look to you, Karla, one of the themes today I had said has been data, but I've actually noted, I wish we had these word clouds. Tired has come up again and again and again. No, like in every context, I'm actually, tired mental health issues. Mm-hmm. So I'm delighted you've joined us today, and we'll give the floor over to you to hear now for some opening comments. Thanks.
Mm-hmm.
Thanks very much, Leah. It's a pleasure to be here representing the Mental Health Commission of Canada. And I am joining you today from across the river from Lynn on the unceded Algonquin territory in the Ottawa area. So it's a pleasure to be here. I know, Leah, you mentioned the importance of data, and I think it was one of the things that we recognized sort of in the early days of the pandemic. We knew the impact or the potential impact that the pandemic may have on the mental health of Canadians. And so we started from an early stage doing some tracking and monitoring of mental health. We've done 10 waves now, starting in October 2020, most recently in March 2022, sort of monitoring how people were doing with respect to their mental health. And, this may not come as a surprise to anyone, but as, Jennifer talked about, the pandemic has not affected everyone equally. And we certainly know that women are reporting higher levels of anxiety, higher levels of depression compared to men. And those levels have, dropped in the early days of the pandemic, but have stayed at relatively low levels. We haven't seen them really start to bounce back the way we might have expected as the pandemic started to ease. The other thing that we're learning a lot about is that the pandemic is also not impacting all women equally. We know that women in households, as an example, with young children, are reporting even higher rates of anxiety and depression. Women from low-income households as well have been much more detrimentally impacted. Women who identify as 2SL BTQ plus, also reporting higher rates of anxiety and depression, as well as women from a variety of different racialized communities. So Black women, East Asian women, Southeast Asian women, South Asian women are all reporting higher levels of depression and anxiety as compared to others. There's lots of things that are impacting women. And when we've done some of these tracking surveys, some of the things that are stressors for women include finances. And I know Bea spoke about that and how, the pandemic has really impacted a number of women financially through their employment, either because they worked in industries that were closed at various times, like retail or hospitality, so they lost income, or women that had to leave the workforce because they had other caregiving responsibilities. They were homeschooling their children. They were looking after elderly parents. So certainly finances is a big concern for a lot of women. Women have also been impacted because of social isolation and that disconnection from some of their traditional sources of support and, where they get connection in the community. And we also know that the other thing that's really impacted women has been the burden that they carry around the health of their family members. So whether that's, the health of their parents or their grandparents, their spouses, their children, they've carried a heavy toll, thinking about not only their own health and well-being, but also the health and well-being of those around them. So our organization has been very focused on trying to create some resources and tip sheets that could be beneficial for women, but also recognize that the onus is not solely on women themselves. There's a strong role to play for their employers, who have a lot that they can do to set the stage to enable women to thrive and to have some of those flexible policies that can really support women in the workplace. So that's really been a very important focus for us over the last 2 years, has been also creating some resources that employers can use to re-examine their own policies and workplaces and provide them with some tips and strategies on how they can better support women.
Thanks, Karla. And two of your resources come to mind there. I think we're going to pop them in the chat. One is about, and it's not COVID specific, about women returning to work after maternity leave. And I think there's another one about the hybrid workforce, and really practical. I'd encourage people to look at them. They're one-pagers, right? These aren't big binders that we have to fold through. So thank you for that. And in light of this, right, that, we've all been impacted. There isn't, not everyone's been impacted equally, and even among genders, there is, there isn't an equality of impact there either, to state the obvious. I just sort of want this next question to be, what is the way forward? How can the business community specifically, including women business owners and female entrepreneurs, play an active and meaningful role in this? And I think what I'll do is I'll open the floor to Lynn first. I'll ask the others to react here as well, but I'll also call on you sort of here as necessary as well. So Lynn, as we look forward, the business community is well aware, of Section 92, for example, but what can we even do as women to support women? Any and all ideas, we'd be more than welcome.
Okay.
To. Thank you.
I might be a little bit blunt here, but I'll be straightforward because I don't have much time to talk about what we need to say. But, we are looking for transformational change for Indigenous people. We're looking to develop our own models of healing or deliver our own services, and we need help with that. So we do need community to help and support us. We do have a number of corporations that have reached out to help and help us with programming. I mean, I just can't express enough the need that's out there, and there is a serious shortfall in funding that we have. So we need help in that way. We do have corporations that reach out to us. If any of you are out there and know, can help us in any way, we have a team over here, and we try to work with different organizations to get the help we need during this situation post-pandemic. So I think that we're going to reach that transformational change, but we're going to reach it together, not just Indigenous people with the government of Canada and that terrible dependency that's been created, but rather, with all Canadians and different organizations and even corporations that want to help. That corporate responsibility is coming out. We see it. We have a lot of people reaching out to us. So I think this is a plea for some assistance that we can get from corporate community or anybody who's out there, really.
Thanks, Lynn. And I like that idea of, not only by community, for community, Indigenous communities included, but the idea of partnership, right?
Yeah.
And togetherness. That's fabulous. And Jennifer, I'm going to send it over here to you, because Jennifer promised me on a bunch of our pre-calls that it was going to get heavy, but she's got the way forward. So this is your moment, Jennifer. No pressure.
Well, I don't think it's heavy. I think it's, just being very, very pointed. And I think, to Lynn, we have to be blunt. The investment in women's health particularly is minuscule compared to other parts of the healthcare sector. Funding that is directly put towards women's health is around 8% of overall healthcare funding. Again, although we make up more than 51% of the population, about 23 to 24% of the researchers are female in academic institutions. A fraction of those are racialized, very few Black, very few Indigenous. So you don't have lived experience, you don't have that intersectionality, you don't have cultural knowledge, and therefore you cannot create cultural safety, and you can't ask the right questions because you don't know them. So investment in women's health has to be at the top of the list. And representation, people think that, all people are equal once you get into healthcare. And I'll just tell two quick stories. In Toronto, and I'm sure it's reflected right across the country, we have about 25 specialized urologists, and only one specializes in women's health. And I can tell you, when you go to 25 of them, all of them have lots of experience with erectile dysfunction. Very few of them understand bladder leakage, which is a chronic problem for women, and it's completely overlooked. There are so many things that impact the lack of knowledge in the healthcare system of women's bodies, that women are turned away from emergency departments with heart attacks because our heart attack symptoms are different. In medical school, they're still only getting 1 hour of training on menopause. So this is why when you go to the doctor, nobody knows what to tell you. So investment from the point of view, right from medical school, in a curriculum that is focused on women, but also investment in research and making sure that the researchers represent the communities that women come from.
Thanks, Jennifer. Karla, do you want to add anything to this? I'll give the floor to you and then over to you, B.
Yeah, thanks, Leah. And I guess, when I think about this question too in our audience, I think about as well of sort of, what's the role of employers in this, and what can employers do maybe to support women? And that's an area, as I said, that we've been, trying to provide employers with some guidance there. And there's a lot that can be done, I think, to better support women, to enable them to thrive at work. Some of that, often what we hear is sort of the importance of flexibility and trying to be flexible in terms of when and from where people are working in order to accommodate other responsibilities. And some of it are the really, the simple things about just showing people some kindness and some empathy, understanding the circumstances that they may be in, ensuring that you have resources and different supports available, like an employee assistance program or other kinds of benefits that people can tap into. ensuring that workloads are reasonable, especially given people's circumstances, and where possible, is there a role that can be redefined maybe a little bit to say, okay, we're going to, we recognize the situation or circumstance that someone's in, we're going to have you focus on maybe this part of your role, which is really mission critical, and maybe let go of some of those other pieces. So I think from an employment context, there's lots that employers can think about integrating into that sort of day-to-day to really better support women's health and mental health as well.
I totally agree. I think that's a beautiful way. And from the hospital side, I'll just say very, very quickly, because I didn't answer this question directly, and I feel like I've left it out there, is that, there's a lot of privilege built into the healthcare system. You have to come downtown, usually whatever city you're in, go to a big academic hospital, take a half day off work, pay $25 to park here in Toronto. Now it's $30 post-pandemic. Assume you have childcare, assume you have transportation. And I think employers have to think about, when people are seeking help and seeking support of the healthcare system, giving them that, as Karla said, that latitude, that flexibility, letting them take a call for their healthcare at work, a virtual call, and building that into the system. And also giving people time to take care of themselves. So I think that's beautifully said, Karla. And I would say that our healthcare system presumes an enormous amount of privilege.
Yeah, I do think that employers have an important role to play. I think that, when unions and employers work together to come up with good recruitment and retention strategies for workers in the industry that you come from, that can be helpful, especially when you look at recruitment and retention of women and other marginalized groups. There can be specific outreach done, there can be specific programs put in place, and there can be specific supports that can be agreed upon. So I do think collaboration is always key when it comes to that. But I also want to touch on the issue of harassment and abuse that many workers face within their workplace. And I'm talking about from clients, from residents, from patients, and those types of things. And we recognize that, the general public, there are many mental health issues in the general public, but a healthcare worker, a retail worker should not be going to work, for 8 hours a day, having to manage bad behavior. And so we are looking for solutions to work with employers on those particular issues, whether it's putting in place cohesive policies to address bad behavior, cohesive policies in terms of how we manage that behavior, and what's acceptable within that workplace before that client or that resident or that customer is no longer welcome within your workplace, because that does have a detrimental effect, not just on the mental health of the worker, but on whether or not that worker actually wants to come to work and is themselves healthy enough to be able to navigate those issues. And lastly, I think I would say that, we are always looking for support from the employer groups as well to talk to our federal government about the very important issues of supports for workers so that they can actually go to work. As I said earlier, if I'm a worker and I don't have childcare, or if I have an elder care issue and I don't have those supports available to me in my community, that's going to keep me from being actively able to be employed. And so it takes a whole bunch of aspects for us to be able to work together in order to increase women's participation in the workforce.
Thanks, Bea. And I just want to pick up on a couple threads as we push into questions here. And I read, just a reminder that 98% of the businesses in the country are small and medium-sized enterprises, right? These smaller places, and there's a whole different set of circumstances and realities around that. But Karla, you talked about EAP, but even if you're not able to do that, Jennifer, what you said, little things like allow the time, to take the call, to make the, I've seen us been quite, innovative there in those sorts of flexibilities, knowing if we can't do all in sundry. And B, you must have been reading the questions, because there was a question here about, health and safety in workplaces, particularly for women, and having that, having those working together to have that in place before, almost preventative, not, or knowing or nipping it in the bud as it were.
Right. And
Jennifer,
paying attention,
ahead.
Paying attention, making resources available to your staff. We run the sexual assault and domestic violence program for Ontario out of Women's College Hospital. Employers have an obligation to sort of pay attention to their staff. I remember during the pandemic, one employer realized that one of their staff members wasn't safe at home and was able to allow them to come into the office and have mental health appointments with one of our psychologists and one of our counselors. I think that type of flexibility and that kind of paying attention is so important. We need holistic health, not just, you go to the doctor and you come home. We need employers to be paying attention to the mental health and to the stresses that people are under. We had an explosion of virtual care during the pandemic. Our hospital was virtual long before, but now everybody is virtual. We really need to look at how that worked, assess it, and see what we need to keep for access, because access was a huge issue that we overcame during the pandemic, but not completely. People with poor bandwidth, people that lived outside of the city, people who don't have computers. So ensuring that there's access to healthcare no matter where you live and no matter what your socioeconomic status is so important. All healthcare cannot take place in hospitals, although I work in one. It's so important that we have healthcare in the community, whether it's Indigenous, whether it's closer to home.
I'll just maybe add as well, Jennifer, I'm glad you brought up that concept of kind of looking at health and well-being from a holistic perspective. And I think, Bea, you spoke to this as well about, when we're thinking about health and safety in the workplace, it's not just about our physical health and safety, it's also about our psychological health and safety. And, there have been some standards now that have been developed around that. And it does include having a workplace that's free from harassment and where people are treated with respect and, where their workloads are managed, right? And I think that's a really important shift that we've had in our society over the last number of years, is really viewing safety very differently and a lot more holistically, which I think is fantastic.
Jennifer, when you brought up that issue as well, Lynn, I'm just going to give you the opportunity. I don't mean to put you on the spot. When you were talking about all the silver linings, I thought that was great, but I actually made a note in my notes about the broadband issue, for example, right? It's great to go virtual. It's great to have that access. But have you come up against that? Or even, you've got Jennifer's example of someone being able to go physically when it's not safe virtually to do it within the confines of another setting. Lynn, if you can speak to those experiences at all, that would be great.
Sure. I mean, there's still a challenge, certainly in remote areas. The cost of it and the accessibility is not there. So we are working on that and making some progress, but there's a lot more that needs to be done for sure. In terms of, I think I want to comment a little bit on the policies and going back to work and such as well, because there's some struggles there for people to go back to work and mental health, and you've been working at home and then you have to go back to the workplace. So I think there's a lot of work that has to be done in our workplaces in terms of fundamental shifts in the thinking and open policies for telework. So we have to, again, there's an adaptation. And if we had accommodations before COVID, now it's significantly more accommodations that need to be put in place. But this is where we're going. This is the future. And again, it's about adapting and making sure that we have those policies in place so that if there's any mental health issues that are COVID or not COVID related, that we're able to accommodate accordingly.
Yeah, I agree. The going back to work, I'm sure we've all dealt with it. Doesn't matter if you're a small or a large business. But when we evaluate, I think on a global level, nationally, what we need to do, we're going to have proper representation at those tables. Because who sits at the tables, who does the research, who asks the questions, who makes sure that there's that cultural, ethnic, ageism is a huge issue in healthcare. Older women are almost completely marginalized in healthcare. We saw this throughout the pandemic, despite being the most impacted. And we are a super age society. We have more older people than young people, yet we have 3,000 pediatricians and 300 geriatricians. So who is at the table to ask the right questions, and who are doing things for their own community? As Lynn said, nothing was for us without us. Many communities have these issues. So having the proper representation is going to be key.
Yeah, absolutely. And we talked a lot about this today, the return to work and some different ideas and practices going on. And, in our first panel, the stat was mentioned, for women, I think it was 65%. If we don't, have some flexibility, we're not going back. So,
We just heard Elon Musk, who's like the most privileged human being on earth, just, bought Twitter because, he could, say everybody had to show up Monday morning or they were going to get fired. I don't think he has any childcare issues or transportation. He probably has a few Teslas he can pull out. He doesn't have those, struggles and strains that many women, I think Karla and Bea have talked about, have to confront. There's so many barriers for women and marginalized people, and there aren't resources and pathways for them. So again, who asks the question and who gets the answer is going to be so important.
Absolutely. Go ahead, Karla.
Yeah, I was just going to say, Jennifer, on that front, because, we have been doing some research around people's experiences while working from home as well, and their experience with that work environment relative to their previous sort of, in office or, like on the job site sort of experience. And we're also hearing from a lot of, not just women, I would say women and men from racialized communities, that one of the benefits for them of working remotely is they're actually experiencing less discrimination and less racism and less microaggression. So their work environment has actually fundamentally shifted for the positive through the course of the pandemic and being able to work remotely.
Yeah, and I would agree with that. I've heard that many times. But as we build back our work environments, we're going to have to solve for those systemic issues that were there before. I mean, that sense of belonging that we all want to create has to be created. And I think the pandemic has definitely taken away some of the systemic issues because now you're in your own environment. But I think as we've seen in healthcare, we have a lot of frontline workers from racialized groups, and the abuse, as Bea said, was just astronomical. And so we do have to solve for it. I mean, some people want to come in, and some women do want to come in. Some women, that's the only place they get to sit down for lunch. And so good for us, we should have that choice. But again, I think as we evaluate, because that's the problem, just like in healthcare, it's not a one size fits all. We have to evaluate it, and the evaluators have to reflect all of the populations that will be impacted.
Absolutely. And then there's the issue we've been talking about this morning too. It might be great to be at home, but what are you missing by not being in the office, right? The networking, I got more done in my kitchen at the office than, those conversations with colleagues. Lynn, were you going to jump in here before I move on? I just want to make sure.
No, I just, again, I think that the office situation is important to have an ambiance around that is not like the government's 2.0. We all are, as an employers, have to look at what kind of environment we're having in our workplaces now to not create a situation where people that have been discriminated are hiding at home because they don't want to go back. Like, we have to think about all of that. Those elements, and create this space that we want. If we want people to come back to work, create that space, right? We're responsible for that as employers.
Yeah, and the stress that people feel, whether coming to work or at home, actually impacts their healthcare outcomes. Your mental state, the stress is one of the worst accelerators for health issues. And so making sure people stay healthy, holistically is so important. And we won't have the outcomes we expect unless we actually address some of these systemic issues.
And that's where I would always say, actually talk to your employee group first and foremost, invite a conversation, whether it's unionized or not unionized, talk to your employee group. What's missing? What makes our workplace a safe space, physically and mentally a healthy workplace, right? Because as Karla pointed out, there are new measurements in terms of how we guide ourselves in terms of workplace safety and health. It's not just the physical aspect. It's not just making sure the lights are on in the parking lot at night, but it's also, is it a mentally healthy workplace for me? So talk to your employees, actually invite those conversations and have a sit-down discussion about why that is not the case or what needs to happen in order for that to be the case.
Mm-hmm.
Yeah, on that note too, Bea, we do have a question here about mental health, and I remember doing this about, it was probably this summit last year, right? We always knew there was a health crisis, but quick on those heels is this mental health crisis returning to work. This is just the beginning of the journey, right? This is not the end. But the question here is, we know that there's a crisis and wait times to access to mental health services continue to increase. what can be done to address this? Thanks.
I'm
Go
going
ahead.
to speak a little bit. You know, I'm not a psychiatrist or a psychologist, but at a system level, what I've seen is that, particularly in mental health, you know, all healthcare is done by acuity. You triage people by how ill they are and, you know, how acute they are. And in mental health, it seems like, you know, it's like a supermarket with everybody in the same line. It's very hard to distinguish who is more acute than the other. So what I would say we need are really simple tools that we can bring to at the community level, where people can enter the mental health system based on where they are. Some people just need a little bit more information. Some people need support. Some people are like life and death. And so we learned a lot, particularly at Women's College Hospital, because we did not close and we delivered all our services virtually, about how to have group sessions around how to triage people who just need more information so they can make the right decision, how to get those people that are most acute to the front of the line. So I would think in mental health, one of our biggest issues is that one size fits all approach and everybody being in this big lineup and not getting to the most acute. We don't have enough beds, we don't have enough resources, but our virtual capacity can help. We had a great story of a woman in Southern Ontario during a snowstorm having her first postpartum appointment, and she thought she was going to have to miss it. And we did it virtually, and she didn't have to miss it. And that was life-changing for her, you know, suffering severe depression after the birth of her second child. So we do have to look at all the things, all the tools in our toolbox with mental health, and not have everybody lining up in the same line to see a psychiatrist and waiting often months and weeks and years.
I could not agree with you more, Jennifer. And there's some really like promising models that have been used in other countries, and we're starting to pilot them here in different provinces and territories in Canada as well, that essentially look at, you know, what they call in the sector sort of stepped care models, where, you know, certain people can go online and maybe they get, you know, some tips and resources and do like an online self-assessment, you know, that helps them manage things from home. Maybe some other people then, you know, go to a group session or have like a phone check-in with someone and get a little bit of guidance. And it's only, you know, a very small percentage of people, as you say, that may need to go see a psychiatrist at the end of the day.
Right.
But, you know, some of those models are showing that, you know, we worked as an example with the province of Newfoundland and Labrador. Over the course of a month, they were literally able to reduce their wait times to zero by implementing some of these approaches, when they'd had people on wait lists for 9 months, 12 months, waiting for appointments. And so it's exactly that strategy, Jennifer. It's about triaging people so that they get the right, appropriate level of care that they need in the moment.
We have a similar program, Karla, called Our Moving, which we just finished testing, and it was so successful. We're going to roll it out probably provincially, because you're right. So many people just need the access to different levels of information that are available now. And again, I don't know if we're going to be able to bring the wait time down to zero, but significant impact. And this is something that can be spread right across the country, where everybody can benefit, and it can be culturally sensitive. You can use people's intersectionalities to make sure that they get what they need. And it can be delivered in small communities who often don't have access to high-level psychiatrists and psychologists on demand. So we're very excited about that program here. And it sounds like that we're doing that in other centers. And that's what we need to do: collaborate and scale. Because we're relatively a huge country, but a small country, you know, 40 million people, we can do this. You know, we can scale and reach everybody.
And I love this. I love all this positivity, right? In the collaborate and scale, in the silver linings. And these are actually really encouraging and important for us to hear and understand about, right? In the mental health space, as well as, you know, be what you were saying about even in the workplace, right? Even if there isn't, you know, whatever structure there is, to have those conversations about health and safety, and all, you know, whether it be within the workplace itself or what you might be bringing from home too. And Jennifer, I'm going to see you nod there. But
you know, I think in the workspace, you know, there's so much stigma, particularly around some of the chronic diseases and some things like mental health. And I often tell employers, when somebody says, I'm not feeling well, I'm not myself, just, substitute whatever they're talking about in terms of their mental health with I have cancer. And the empathy people have, because we're a cancer center as well, when people say, I've been diagnosed with cancer, I need to go to my chemo appointment, or I need to go to my oncology appointment, people are like, no problem, of course you need to go. We want that same level of empathy, investment, and support in mental health and other parts of the disease spectrum, particularly for women. I feel like, the cancer conversation has done really well in making sure that stigma around talking about it has been removed. But in other areas of health, which are just as devastating, quite honestly, there are things that happen in dermatology that can impede your life and stop you from being able to leave the house, but nobody talks about them. And the bladder control issue that people laugh about and is filling our store shelves is a real issue for women that can impact their quality of life for decades. So these are things that women have to be able to, you don't have to tell your intimate secrets, but we have to normalize being able to take care of ourselves and not feel that we are less than because we do that, and that we deserve to do that. And it shouldn't take something like a cancer diagnosis for an employer to say, go take care of yourself.
Absolutely, Jennifer. And thank you for that. And thank you to all of you. Of course, we're always at the end of our time too early, but just want to tell our audience and participants, we'll be looping back with some resources. We'll get Lynn's contact, and others have provided, we'll provide information about where to get some more information about a lot of this. So a big thank you to all of you for joining us here today. It's an important conversation and one we hope to continue.